The next lecturer is a good friend and also someone I've known for many years, Martin Paulus. And Martin did his postdoc here, working, I think, with Arnold Mandel. And also, when he came in about 1986, he also had a lot of contact with David Siegel. That's a name that you hear often. He had a major emphasis on many people in the department. And Martin had then worked his way up. He's extremely good at mathematics, very good at basic research or at research methodology, and a wide range of skills, including his fMRI work. Then, good for him, bad for us, in 2014, he became the scientific director and the president of the Laurent, I hope I've done it okay? Laureate. He'll do it. Okay. Institute for Brain Research. And what they do is that they work on neuroscience and fund neuroscience projects and to better understand assessment as well as prognosis. But I can summarize the next part by saying the truth is he's never left us because he comes back twice a year. I was going to sing that line, but I decided not. That he comes back at least twice a year, and he tries to help people who are writing grants to be able to increase their skills. Well, it's a great pleasure. Both of your next speakers are people who worked closely with me, who knows nothing about fMRI, on an fMRI study that was highly successful based on what we were trying to do. But I give you Martin Paulus.
Well, first of all, I want to thank the organizing committee for inviting me to actually present here today. Before I start, actually, because this is a special occasion, I'd like to take maybe a minute to thank a number of people. The reason why I'm doing what I'm doing now is all because of people that are either in this room or that have worked in this department. So I'm going to go through a list of people, and I'm going to try to thank them for what I think is has been the most influential aspect on my career. And with those kinds of things, there are two things that always happen. I thank them for the wrong thing, and I don't thank enough people. So don't feel excluded. I know that that actually activates the insula. Don't feel excluded if I don't mention your name. There are many people that have really influenced my career. So, but I would obviously, the first person to thank is Arnold Mandel. I started with Arnold, actually with Karen Britton and Arnold. And Arnold really taught me how to imagine and think science. I think there's, everybody would probably agree, he really is a true genius. I was very fortunate to work with him for a couple of years. Then I worked with Mark Geyer. And Mark really had enormous patience. Everybody who knows Mark knows he's a fantastic teacher. And Mark really taught me how to write scientific papers. He improved what was really a pretty abysmal starting point and made it into something that hopefully is now decent. And then shortly thereafter, I met Lou. I've worked for a number of years with Lou. And I think what Lou was able to do, he was always able to see what are the kernel of the important ideas. And he really helped me to also see how to prioritize and strategize and build really a research career. And he's been a tremendous mentor to me, just very hard to express truly. But at the same time, and at the same time as I met Mark, I also worked with David Braff. And David Braff, as many of you know, he teaches you how to think outside the box. You know, he has these kernel of insights that sometimes strike you, just like a lightning. And it was really a tremendous honor to work with him for these years. And then, and I still remember one of our first meetings, I met Mark Schuckett. And as Mark very readily points out, as nonlinear as Arnold is, as linear is Mark. This is, for me, was actually something that was very, very valuable. I think I would not be able to do the kind of clinical research that I'm doing now without Mark's help. Mark is also, as you probably have already gathered, a very strong organizing, managing person. So when I gave one of my first presentations at ACNP, he actually afterwards contacted my program officer and made sure that the slides were done the way Mark thought the slides should be done, and I think I succeeded. I was able to get grants and be funded. Unfortunately, Greg is not here. Mark already said that Greg Brown was very instrumental in teaching people fMRI. He has had influence on so many people in the department to make fMRI a standard tool in the department. Obviously, Murray Steen. Murray and I have worked for many, many years, and Murray has had more than just a scientific impact. He had a personal impact. And we still collaborate, and it's been one of the incredible relationships that I had here. And, you know, as you get older, your colleagues get younger. I worked for many years with Susan, and Susan Tapert is a gem. She is really an absolutely fantastic person. We had a center here together, and she can organize like maybe only second to Mark. Hamp and I worked for many years in the VA. Hamp really helped me to navigate a very complex administrative environment at very turbulent times, and I will be forever grateful for that. I'm almost at the end, so and I will cut my talk short because I know what the time is, and I'm mindful of the time. I want to mention two more people. Walt just talked, and Walt and I met a number of years ago, and we started to really bring the two expertises together. As you've just seen, anorexia is one of the most complicated and complex psychiatric disorders that there is, and so it's very, very difficult how to parse these disorders. And we've tried, and in some ways I've been able to work with Walt in gaining a deeper insight in how to begin to parse these complexities. And lastly, Igor. Igor, many years ago, we all know Igor is fantastic in running large research organizations. And before I actually applied for the P20 here, I went to Igor and I asked him all the different details about how to run this, how to actually do this. And it's really only because of his insights that I've been able to run these large organizations and now run the Laureate Institute for Brain Research in Tulsa, Oklahoma. So I wanted to thank all these people before I start talking about the science, because I do think that it shows you, and it shows for people who are maybe younger in this audience, that there is a fantastic career in this department, and you can make connections and really grow in this department. So. Okay, so my task was, and this is again, Mark told me, to talk a little bit about fMRI and prediction. And so what I want to do is I want to talk about two things, and I probably won't get through all of them because I've already cut myself 6 minutes out. But I want to talk to you about sort of a general approach, which I think is important to kind of take a step back and see where we are. And then I'm going to give you a particular example, actually an example of somebody who I have worked with here and continue to work with here, Katja Harle, who is a computational cognitive neuroscientist, and just give you sort of a flavor of where this work is going. Okay, so a couple of years ago, I wrote this opinion piece in JAMA Psychiatry where one of the things that I've sort of felt has been missing is that in many of our research questions, we really have not stepped back and asked ourselves, are we asking the right questions? Are we asking the questions that the stakeholders, the people that we are responsible to, that pay our grants, or the patients, or the payers, or the policymakers, are we asking the right questions? And I think this is important once in a while to, particularly as a clinical researcher, but also as a basic researcher, to ask yourself, are we addressing the proper questions? And so the bottom line here is that there's two directions that one can go. One can put emphasis on primarily asking questions that whose primary goal is an explanatory mechanistic disease model. And I think we heard this morning some beautiful work on the very cellular level that help us to understand mechanistically how memories are being formed, for example. And I think that is also important that is why it's important that we continue to have a strong preclinical and animal and molecular research core, because you cannot ask these questions in the human. I mean, people are trying to, and I know that Josh is very interested in putting electrodes and dyes into people, but we're not at this point yet. But the other element of it is asking pragmatic questions. And the pragmatic questions is really something that should generate a difference in how we treat our patients. So my interest there has been primarily trying to address questions of predictions, and that's what I'm going to tell you a little bit about. So I think we should keep that element in mind. So one of the issues, initially, and this was work when I was doing work with Mark and Susan, I felt very strongly about prediction. But in the meantime, I've turned around and also have come back to explanation. Because it turns out, and this is actually interesting, there are not many studies that have been done, and ask the patients, what do they actually want when they come to a psychiatric office? And explanation is right on top of that. It means that we have to provide empirically based good explanations for the disease, for the conditions, for the failures of our treatments, for the things that we encounter on a day-by-day basis. And so it's not just enough to build predictions. The difficulty, of course, that we're facing, and Ken Kendler has really written beautifully about this, is that our diseases are all based in first-person mental experiences. That and somehow, and I think this is very important, we need to retranslate back these first-hand experiences into something that we can actually work with empirically. And then obviously, and this is something else that is kind of occupying me at this point, is that our diseases are incredibly heterogeneous. It actually turns out that probably 80% of the diseases that we call by one name are made out of different individual diseases. And we need to keep that in mind. So now I want to talk a little bit about computational psychiatry. I'm very excited about it. It's sort of a return in some ways for what I've done with Arnold many years ago. It's changed, but in essence, it's still very much at the core of what I'm interested in. So let me try to contrast the old to the new approach. In the old approach, what we did is we basically studied behavior. We then basically obtained a functional image or any other neuroscience-based assessment, and we used a correlational approach pretty much to relate the behavior to the brain. And there's nothing fundamentally wrong with it, but I think it has a limited explanatory depth. What computational psychiatry can do, it can actually help to deepen our explanatory understanding. And the way it does it is basically, in computational psychiatry, what you're doing is you're putting a process model between the neuroscience level and the behavioral level, or between the neuroscience level and the symptom level. So, and this process model, or the group of models, is how you think the person actually computes what you are observing. And then you directly test. It's not that you come up with this wonderful model and you can say, oh, this is great. You directly test whether this is actually the way the behavior falls out. So that is really, I think, one of the major advances. A lot of excitement about this approach. And also then this gets us into, this can help us to really come to a new level of biomarkers. Biomarkers has been thrown around, the term biomarkers has been thrown around a lot, but I truly believe that with these process models, we can get to a new level that is both explanatory, because it explains how behavior comes about, but also pragmatic. It can predict what's going to happen to people. Okay, so now let me just tell you a little bit about one example. And this is a small example, but I want to highlight most of this work was done here by Katja Halle. And it's an extension of work that really I started many years ago together with Mark Schuckett, when we took patients from the alcohol and drug treatment program at that time in the VA, and we scanned them and we followed them, and we determined whether imaging would be helpful in predicting relapse. And so we've expanded on this theme since then. So just as by way of background, very briefly, we know that stimulants are still a problem. In fact, it turns out now stimulants are coming back. Over the last 3 years, the mortality due to stimulants has increased threefold. So, and part of that is because people who use opioids starting to use stimulants together with opioids. And this is something, so, we all know, and people who've been in the field long enough, in the substance use field, that drugs go in cycles. And that obviously we're still in the midst of a terrible opioid epidemic, but we shouldn't forget that stimulants have traditionally had enormous impact. Now, of course, we all know that the way stimulants exert their acute effects is through the dopamine system, and here just sort of some of the main players. Don't want to go too much into it. I want to show you one graph that is really sobering in a no pun intended way. And that is this graph. This comes from work by Brecht and al. This is the basic survival curve of people with methamphetamine dependence. And what you see is essentially a dramatic fall off in terms of the sobriety. And at this stage, we basically have no pharmacological or really any approved treatment for methamphetamine or amphetamine use disorder. So let me just, since I only have about 2 minutes left, if I'm half a minute over, let me tell you just very briefly how this computational approach works and what we can do with it. So in this particular case, we used a task that's been used widely by many laboratories called the stop signal task. The stop signal task is a very simple task where you have to push a button as quickly as possible, either one side or the other, except when you hear a tone, then you have to stop yourself. And basically the inhibition, the holding yourself back, is what this task aims to measure. So what we did, in fact, this work was also initiated here with Angela Yu in cognitive science. We put on top of that a dynamic Bayesian decision-making model. And the idea in this model is that what you're doing while you're doing this task, you form a model of the underlying statistical structure of either getting a go or a stop trial. So in other words, every trial you encounter, you don't just go in blindly, but you actually have an idea how likely am I going to encounter a stop signal. And this is basically outlined in this. This is essentially the model. Since I'm almost out of time, I won't tell you about the details. But suffice to say, what this allows you to, it allows you to basically do step-by-step computation and arrive at a measure that you can then look up in the brain. Is it somewhere processed in the brain? The two key measures that we looked at here is what's called the signed and unsigned prediction error. A prediction error is basically you're guessing something will happen with an 80% chance and it happens. Then it is 100%, right? So then you have a 20% prediction error. Or you're guessing at 80% and it doesn't happen, then you have an 80% prediction error. So, and the signage is simply whether it's more than what you expected or whether it's less than what you expected. So we looked at those two things because these are very important in forming models of your environment. And so what Katja found is that when we looked at these signals and when we found the areas in the brain that actually computed these same signals were also related to the degree and the percentage, the risk of relapsing about a year later. And this is basically shown in this very simple graph. And I only want to show you or point out the right side of that graph because it's actually a fairly intuitive way of thinking about what we're trying to do with tests. So this is what's called a Bayes nomogram. And it has three lines, left, middle, and right. On the left-hand side is what your prior probability is. That means what you already know about a person or what you think you know about a person. In the middle is what's called the likelihood ratio. And that tells you what the test actually tells you. And then on the right-hand side is the probability that you now have about the person based on the test that you just performed. And obviously what you want, and this is a positive test, and this would be a negative test. So what you want in a pragmatic sense, you want to get a test that will push this blue line very much up, and this red line very much down, because that then would tell you that you have a lot more information once you ran the test compared to when you did not run the test. And what we showed here is basically with this computational approach, we can increase the posterior probability to about 70% prediction accuracy of relapse, and if it was negative, to about 15% prediction relapse. So that's basically what you're getting out of this pragmatic approach. So this is just telling you what this is. And so let me just say, again, briefly summarize. What we found, and I didn't go into detail because I'm a little over, that trial-wise deactivation due to an unsigned prediction error in areas that we already know are important for the stop signal task was actually predictive of relapse. And weaker neural responses to a signed prediction error in another area that is very much involved in this task as well provided another robust predictor of relapse. So the way to think about this is what's going on here? Well, what we think is happening is that methamphetamine-dependent individuals are more likely to relapse because they have a less developed internal model of their environment. In other words, they are surprised by things that they shouldn't be surprised by and then don't know how to properly act. That's essentially the bottom line. So I want to thank a few more people. Obviously Katja, who done the work, Crane Wang, who was actually a grad student here in the CogSci program and worked with me here, then joined me at LIBR, Angela Yu at UCSD, but then also a number of other computational folks, Quentin Hoyce in Zurich, Tiago in Lisbon, and Michael Browning in Oxford. And again, thank you for your attention. I want to apologize for being a little bit over.
No, you weren't. Actually, hold on a sec. Can you go one slide back?
I can go back.
You can do it. Good, super. Could you tell us whether your material in bold was pre-existing or whether it was it occurred perhaps because of the use of
Yeah, that's a very good question, and this is actually something that I wasn't able to tell you much about. We've done the same type of study with people who were experimenting with amphetamines. And this is actually a study that Susan and I have done over a number of years that was funded by NIDA. And what we find is that most likely, these are, or let me say it, predominantly pre-existing condition.
Let me ask, and again, we have a little bit more leeway here in this session than we do in others. Could I have come to the same conclusion had I measured their impulsivity or some impulsivity-related phenomenon? Is that basically what you're studying? I'm not saying it is. I'm just asking.
No, that's a really good point. To some degree, yes. We know that impulsivity is related to stop signal behavior. When we, though, looked at questionnaire data in this particular incidence, we were not able to predict a relapse. And so I think you have greater precision with these computational tools together with imaging. But obviously, we're hoping to potentially develop this into something that can eventually make its way into the clinic, because we all know that it's very unlikely we're going to put every methamphetamine individual in the scanner. So yes, it is in the same domain of impulsivity, but impulsivity as a computational process. And the idea here again is that when you don't have a good internal model of the statistical characteristics of your environment, you are not you're less well able to adapt appropriately. And then when there's a cue coming on, because of course many of these relapses happen when people are exposed to cues that were previously paired with drug use behavior, you cannot hold yourself back.
I had a lot more questions, but they'll come up as we get to the general question period. As I said earlier, that I don't know anything about fMRI, but Susan Tapert and Martin Paulus, and Martin was the driver on this. I wasn't going to go this direction. We were working with the low level of response to alcohol, the need for a lot of alcohol for effect. It's kind of a blunting of a recognition of what's going on in your environment. And obviously, it was interesting to see what was happening in the brain, and turned out some very interesting findings. The best summary of that, I think, is Martin's first authorship in JAMA Psychiatry, or the Archives of, I believe that's where we published it, or it could have been Biological Psychiatry. But it was directions, except for these two, I never would have pursued, and was very important toward my work. I think fMRI is a marvelous tool.